So I'll be speaking on the one of the difficult topic of mega prosthesis tips and tricks. We know that one of the most important challenges during the revisions is how to deal with the bone defects with its size variability and different locations. Indications of mega prosthesis are extensive bone loss for any reason, bone loss in prosthesis extraction, usually the cementless prosthesis extraction, bone tumors, and cases treated for the infection with extensive bone loss. There are huge number of risks involved with when you do a mega prosthesis. The aseptic loosening is one of the commonest thing. Wear of the joint components because the whole of the pressure is coming onto the joint components. Breakage of the prosthesis, breakage of the stem, periprosthetic infection which is very high in case of the prosthetic mega prosthesis, fatigue fractures and dislocations. And we'll discuss almost all these complications. To start with, this boy, young boy, was operated for a tumor in Russia. And what we see here, the prosthesis had failed with the rotatory, the block at the link, which is here in this prosthesis, was broken, and that's why this patient was having the rotatory instability of the thigh. That's why the patient was revised. The previous implant was removed. Thorough wash and debridement was done. The mega prosthesis, distal mega prosthesis was used. And this was giving a good fixation. We can see that it's a reasonably good fixation here. But the post-operative implant wash, it shows the staphylococcus bacteria. So it is very important if you do a mega prosthesis revision, or even because these are the long surgical procedures. Followed by this, if you detect a bacteria, give the antibiotic for a period of 6 weeks. That's what we do, intravenous, and 6 weeks of oral antibiotics. You see this patient at a 1-year follow-up. See that patient is doing reasonably well. He is able to walk well. He is able to sit well. And we can see that the function is reasonably acceptable in this patient at a follow-up of 1 year. See that patient is able to walk almost without a limp and with a reasonably stable knee joint, and was able to sit comfortably, as what we'll see him here. And this boy was doing the many activities which probably we should have asked him not to do so much. When we see this boy at the follow-up of 1.5 years, he seems to be doing well. And then you see that there is some amount of space coming up at where the stem is connected with the proximal femur. You see it more in close observation. And here, this patient had a inability to walk after just a little bit of jerk. At 18 months, the stem was broken. That's what we see here. The implant was revised to a thicker stem, and it was providing a very good support. This is before the breakage of the stem on the left side. On the right side are after the revision. And we see that the major concern, as we discussed already, because of the extensive soft tissue dissection, and approximately 70% of the post-operative deep infection presenting within 12 months of surgery is a common feature in mega prosthesis. In fact, one of our paper on this has gone to the Journal of Arthroplasty. And you see this patient is doing excellent after this revision surgery at the follow-up of 7 years. But then at the follow-up of 10 years, you see that there is a breakage of the component at the knee. And this patient is still walking and planning for the surgery now. Another example, a patient having the lytic lesion in proximal femur extending right up to the distal femur. You see it here that there is a lesion was extending almost throughout the femur. So the decision was done to do the entire femur replacement. Femur bone was isolated, removed carefully, avoiding damage to the neurovascular structures, taken out, measured, and then the femoral replacement was done. Proximally, we use the constrained liner. And we see that the whole neurovascular structures were safe. Prosthesis implanted with the constrained liner and the rotating knee hinge. Post-operative at 2 weeks, patient was able to stand. At a follow-up of 5 years, he was able to walk, albeit with a small amount of limp, and was using a cane. That's what we advised him. And you see, at a 5 years and 3 months, he sustained a little fall, dislocated the hip joint, and this dislocation was because of the polyfailure. The ring was broken, and that's how this was revised. 6 months post-operative, patient is doing well. So the design philosophy is important, improving outcomes with the better anatomical designs, better rotational stability with hexagonal stems, and also the cementless fixation for the primary segmental bone tumor prosthesis is a preferred option as of today. The secret of success are careful preoperative planning, selection of the appropriate prosthesis, meticulous surgical technique, and careful patient selection. Take-home message: mega prosthesis should be used with minimum 10 millimeter or more stem. Adequate length and diameter of the stem and adequate cementation at the neck stem junction is very important. Cementless stem may be a better option, and broken stem should preferably be removed by sequential over-reaming to avoid damage to the bone, and patients may be advised to reduce their level of activity as much as possible. Thank you so much.